Hello, anatomy colleagues. This is Dr. Alsop. And now that we're starting to feel comfortable regarding the bones that are associated with the skull or the head, let's talk about some of the joints. All right. So those bones that are coming together and articulating will form various joints. And you see that there's quite a bit more detail regarding these learning objectives. This will help guide you as we kind of go through these structures associated with the joints of what I want you to know in terms of an assessment. All right, so one of the most prominent types of joints associated with the skull are sutures, and I hope that you remember these from our discussion regarding the joint basics. These are a type of fibrous joints. They are going to be immovable in adults, but there may be some movement associated with children and allows some growth, obviously, to occur in the brain with a little bit more mobility associated with those in the juveniles, but in adults, these are going to be immovable. And there are lots of sutures, pretty much anywhere that you're going to have bones articulating, but there are going to be certain ones that I do want you to at least be familiar with in terms of location and between which bones there are articulations. And a lot of times I like for you to know these because some of these match up with some of those anatomical planes that keep coming up. So you're going to have the frontal or coronal plane or the sagittal or plane that can help in terms of that. So let's start with this coronal. Sometimes you hear this referred to as the frontal suture. You can think of this as kind of like a crown right here. You'd put a tiara right here associated with the coronal suture. And this is going to be between the frontal bone and the parietal bones. So you can see that here in the superior view, you can see the frontal bone here and a parietal bone here. And so that would be the coronal suture there, aligning kind of with where that coronal frontal plane would be. That would divide the body into anterior and posterior parts. The sagittal suture is going to unite or articulate the parietal bones somewhat in the midline, not perfectly in the midline, but somewhat in the midline. So here's a parietal bone here, a parietal bone here, and it's going to be between those two. And you can see that a little bit from this posterior view here. So two parietal bones and the sagittal suture right there. It's called an arrow because when we're talking about a juvenile, the anterior fontanelle would be in this general region. And that's where it gets this arrow name. Again, I have these here hopefully to help you kind of, sometimes knowing the origin of these words helps. It's not something I would specifically ask on. The squamous suture is a unique one because it looks like you just kind of have the bone overlapping so that temporal bone looks like it just kind of overlaps, sits on top of this parietal bone here. So you're going to have the temporal bone and then the parietal bone, and then that squamous suture is going to be right in this region here. Sometimes you see people call this the squamous suture, but generally this has a separate name and not one that I'm going to have you know. Now, right around the squamous suture, you're going to have a craniometric point. And there are craniometric points throughout the whole skull. It's actually a big part of what I did my dissertation on. But this one is clinically important, and I do want us to kind of see how we're going to get a whole bunch of bones joining in one region. So Terion is a craniometric point. It is the point at which the frontal bone, the parietal bone, the temporal bone, and the sphenoid bone basically kind of come together in this one area. And so it's not really, I mean, that's cool and everything, but it's not really, that's not really the point of it that I want you to get at. It's the branches, specific branches of the middle meningeal artery, which is going up to supply the meninges that surround the brain and the spinal cord, but specifically the brain here. You're going to have branches of this that's going to travel deep to this portion of the bone. So if you think of having like a lateral blow right around the area of Terion, that could cause a fracture there. And that fracture could cause for a cut to happen on this branch that could lead to a rushing of blood in this region. And basically what it will do is it can create what's referred to as an epidural hematoma. and that is going to be between the bone and the dura mater, which is going to be the outermost layer of meninges. And as you can see, this isn't good. You see, you have the blood here, and then that's impinging on the brain in this region. And it's an emergent situation. You need to drain the blood out of that region. So every once in a while, these regions do have some functional or clinical significance that I want you to be aware of. And Terion is a really good example of that. The last suture I want you to know is the lambdoid. Sometimes you hear it referred to as the lambdoidal suture. This is going to, and we're looking at a posterior view here. This is going to be between the parietal bones. You can see that sagittal suture in between there. So between the parietal bones and the occipital bone. And this is generally the most complex of the sutures in terms of its zigzagginess. That's a scientific term, but it does look a lot more complex. And every once in a while, you'll have kind of separate bones within the suture, and those are called sutural bones there. And that's more common in this lambdoid suture. Now, one thing I want to note on, or make a note of, is in juvenile skulls, particularly very young individuals, you can have what's referred to as fontanelles, and colloquially referred to fontanelles as soft spots. And these are regions of dense connective tissue between incompletely fused, I should have here, excuse me, incompletely formed cranial bones. Eventually, these will be replaced. I'm going to put formed in here since I left that word out, incompletely formed cranial bones. Eventually, these fontanelles will be completely replaced by bone via intramembranous ossification. But in juveniles, generally as young as 1 to sometimes up to 6, you can feel these soft spots. And really this anterior fontanelle, which is located, and you can see here how that frontal bone used to be 2. It will completely fuse to be 1 bone. And the parietal bones here. So you have this anterior fontanelle located right there. So generally you can feel that soft spot. You don't want to press too hard because then you're getting down into the brain. But if you don't have a springiness associated with that, that could be a sign that there's some dehydration associated with that individual. So the anterior fontanelle is generally the largest and most notable of the fontanelles. The other major joint I want to talk about associated with the skull is the TMJ, or the temporomandibular joint. So the temporomandibular joint. And the bony parts of the TMJ are going to be that mandibular condyle of the mandible and the mandibular fossa of the temporal bone. So that condyle will articulate with the fossa there. And this is a synovial joint. It is a little more complex of a synovial joint in the fact that it has an articular disc associated with it, so that complete fibrocartilaginous disc. And what it will do is it will divide the articular cavity into a a superior joint cavity above the articular disc and an inferior joint cavity inferior to the articular disc. And this will play a role in terms of allowing actions to occur separately. Sometimes they happen together, but in that inferior compartment, so below the inferior disc, you will have what's referred to as elevation and depression occurring. So this is really where that hinge joint is happening. This is the more dominant movement. But we don't want to forget the superior compartment. So above that articular disc allows for protraction and retraction, a more translational movement. And you need that, particularly in terms of that protraction, to get the full depression of the TMJ joint. So let's look at this. So let's start with the more obvious action. And I'm going to have to escape this full view. Oops. Yeah, sure. Let's do that. So let me reshare my screen real quick. You know, fun technology times. So I'm going to play this. I'm going to make this a little bit bigger here. I'm going to play this right here. And this is going to show depression and elevation. And I could just show you myself, but I want to show you with this fancy video. So depression, you can see here, is what we often think of as opening the mouth. And then elevation is going to be closing the mouth. Now, protrusion and retrusion, or protraction and retraction, is a little bit more conceptually difficult. So protraction, I think of like jutting out the mandible. You can see that on me or on this individual. And then retraction is bringing it back. Okay. Now, I do want to make this bigger again now in order to get back into some of the details here. So those are the main types of movements that can occur. Now, you can obviously have issues associated with the TMJ. If you've ever heard of somebody say, I have TMJ, what they really mean is they have Tmj syndrome. We all have a TMJ, right? We have two, right? But what they're really talking about is they have issues associated with their temporomandibular joint. And a lot of times, generally, the major thing that is the common complaint is dull pain. And generally, you feel that dull pain around the ears because that TMJ is right there next to the ear. There can also be tenderness associated with the muscles of mastication or those chewing muscles. And then it can also involve crepitus or joint clicking. So if you ever hear that, that fairly distinct type of clicking that can occur sometimes when you open up your mouth, that is a sign. Generally, it can not be that big of an issue, but if it involves pain as well, then that's something that's more serious. There are so many different causes of TMJ syndrome. Not one equals definite pain or definite tenderness of muscles of mastication. But these are a few of them. Misaligned teeth, grinding or clenching the teeth. That not only can affect the teeth and the TMJ, can also affect your muscles of mastication. Trauma can, of course, affect any joint. And then arthritis. TMJ, the temporomandibular joint, is a joint, so arthritis can affect it as well. All right, excellent. We have reached the question. So which of the following bones which one does not articulate at the Terion craniometric point? So think about it. You remember that point right here. Which four bones are going to articulate? And then let's cut out the last one, which hopefully you are agreeing that it's going to be the occipital bone. So the frontal bone, the parietal bone, the sphenoid bone, and the temporal bone all meet up at Terion, which has that branch of the middle meningeal artery deep to it. If that middle meningeal artery is disrupted, that can lead to an epidural hematoma, so medical emergency. The occipital bone is too posterior for this, so this would not be the correct answer, or this would be the correct answer to this question, but it would not be involved with the formation of Terion. All right, excellent. Well, thank you so much for joining me here. Now we're going to move into some of the muscles that are associated with the head. Thanks for your time.